predisposed to maybe having a functional problem, but also having pain when they're doing one of these functional tasks. So again, with an asymmetry, it's when an area of your body is in a less than ideal position, causing less than ideal functioning. It can be from trauma, slip and fall on the ice, but a lot of times it's just from being sedentary. Let's see here. And it's not bad to be asymmetrical, it's just bad when you get stuck in that position. Okay, it gets a little thick here, but the list of asymmetries, the reason, some of the reasons why we're asymmetrical is because even though we've got the same muscles on the outside, biceps on each side and quads on each side and abs equal on each side, the way that our guts are put into us are a little bit different. So we've got a 3 to 4 pound liver on the right, a 12 to 14 ounce spleen on the left. The diaphragm on the right side is going to be a little bit domed because it sits on top of your liver. Your heart's a little bit off to the left. You've got 2 lobes of your lung on the left and 3 on the right. Your vagus nerve is going to be a little bit longer on one side, and your nervous system will tend to push you to the right. These are all good things. It's just when we tend to be sedentary, it can cause pain and dysfunction. And a lot of times when people are like this, they'll be stuck in these patterns for a long time before they even start to hurt. So it's not the end of the world when you see these things. It's just when they're starting to have symptoms, we want to go after it and correct it. So just a quick anatomy review. I mentioned just in the last slide how the diaphragm is a little bit higher up and domed on that right side. So in this case, this is just a picture of the diaphragm. So if we go back to our guy with the rib flare, he's going to be flared forward with his left rib cage. His right side in this case is going to be turned back. So I'm just thinking of the rib cage as a left and a right. So what happens now is when his left rib cage is flared forward, his diaphragm is going to be put in a less than ideal position. So why does that matter? It wouldn't, except that now he's going to start using accessory muscles to breathe. Here's a case of a guy who's flared on both sides. And when you start to use accessory respiratory muscles instead of your respiratory muscles to breathe, you'll start getting a lot of neck tightness, a lot of back tightness. Your posture can get thrown off. It can throw off your function. So you'll start to use those accessory respiratory muscles. And so this is, sorry, that's a little green. This is a picture of somebody with emphysema. Somebody like this, they kind of have to use those secondary respiratory muscles to breathe. But you'll see the SCM, the scalenes, traps just turned on all the time. The people that have muscle imbalances without any lung pathology, they'll do the same thing, it just won't be quite as extreme. And where someone like this, he kind of has to do it. If you can correct your muscle imbalance patients, then they won't have to use it. You can help get them out of some pain with that. So some more asymmetries, we'll see scoliosis, we'll see excessive hamstring length, we'll see foot issues, we'll see scapular winging on one side or another. And with all these things, the goal is to correct them and limit the stress. You can have somebody go on vacation and start drinking. That will limit stress too, but not always in the cards for everybody. So if we get the people into a better posture, that can help them feel better. We use corrective exercises. And some of the things I'll look at in the clinic would be, and not that you have to know any of this stuff, but I might look at shoulder internal rotation. On the right side, they have a tendency, not always, but they'll have a tendency to be a little bit restricted. I'd like to see them go parallel with the floor. Her, in this picture, she's about 45 degrees, and when I see that, sometimes it's on one side, sometimes it's on both, I start to think I've got a rib flare that I'm dealing with. It can affect pain levels all over the body. We'll look at, this looks kind of like an Ober test, and I'm just looking to see how well that left leg will drop down. And that tells me a little bit about position of the pelvis, if it's tipped forward and rotated on one side or another. And then we can do some functional strength stuff with our folks there too, but all just different things to look at to try to point me in a direction of what asymmetry might be coming in the door. So with corrective exercise, we'll see, I like to break it up into 2 big categories. One is not CrossFit. We'll see a lot of CrossFitters. You guys probably don't see as many CrossFitters, which isn't a bad thing. I don't know if we have any CrossFitters in the room. But they work out hard, which I'm okay with, as long as you can work out smart. I just like to pick on CrossFitters whenever I get a chance. But we don't want to put fitness on top of dysfunction. So there's a famous guy in the world of PTs named Gray Cook. I stole this line from him. And he says we don't want to put fitness on top of dysfunction, which means we want to get a good base level oh, I don't know, people in a good alignment, you could say, people with good strength before we start doing higher level functional things. So in this case, what I do is I like to break up the exercises into 2 big categories. The first one is going to be getting that person repositioned or getting them neutral. The second one is getting them retrained. So the retraining part is, okay, we've got everything under control, we've got them where we want them, and now we want to start to get you stronger so that you can walk to your mailbox, you can stand up and get out of bed. A lot of the neutral and repositioning things you can do in bed or in a chair, or really any position. So my analogy that I like to use is if you've ever seen anything on TV with Amish people building a barn or a house, you'll see guys in funny hats and beards, and they'll be pulling on ropes, and they're working to get that first frame of the barn up, first frame of the house up. That would be like getting somebody repositioned or neutral. That's like our first step. But in the movies, there's always like a rope that breaks or something, and that first frame of the barn that they get up comes crashing down. So in order to prevent that from happening, we want to not only get them repositioned to get that first frame of the barn up, but then we want to build the rest of the barn around them. Get the walls up and the roof and everything else, and that would be like the retraining part. That's just how I think of it. So if we come back to our person with the rib flare, we want to correct that rib flare, start working a couple different muscles to correct it, and then from there, we can do more advanced exercises. Maybe not planks for everybody. Maybe it's standing up. Maybe it's whatever the functional activity is, getting them up, getting them moving. Let's see. So I keep talking about getting repositioned and getting neutral. How do we do it? So my favorite one, and it's not right for everybody, but my favorite one is blowing up a balloon. So this is part 2 of crowd participation. And if anybody is allergic to latex, you don't have to do it. And if anybody's allergic to latex and not comfortable with the room of balloons being blown up, just let me know. But if you guys are cool with it, I'm going to pass out balloons, and we're going to try this blowing up a balloon exercise, which is like one of my favorite things to try. Yeah, I've got one in there.
Okay. Don't forget Holly behind you.
Thank you.
Thank you. I know, but I like that better. Hey. Pull this up and make it whistle. Should we make us? Today we're going to play with Wow. That was Lily. That was Peggy. Such a kid. First she wants the red balloon. Now she's going to have to play with it now. Okay.
Okay, so for the balloon, we can do lots of different things. Now, in this position, I wouldn't expect you to get everybody, because I don't get everybody in this position. But you can do a lot of different things. You can get abs going. You can give them a ball between their knees to start to get their adductors to fire. The balloon is just like adding a weight to your diaphragm. And it will actually help as we exhale, it gets your abs to fire a little bit. The arm over her head, she's got her right arm over her head to help with an internally rotated rib cage on the right. So there's all different types of things we can do. Now some patients, I'm usually modifying it, so I'm not doing it like this with patients. You can do it in a recliner, you can do it in bed, you can do it in a bunch of different positions. You know, the only time off the top of my head that you may not want to do it is if somebody can't actually blow it up, and I'll have gym rats in the office sometimes. They could probably bench press 500 pounds, but they can't blow up a balloon. So if they can't do it, that's okay. You can give them a straw to blow through. You can just have them exhale and do it and just pretend like they have a balloon. It still can be effective. So they don't have to have a balloon. It's just kind of a cheap lecture trick to make everybody wake up. But what I want to do here is, so I'll walk you through how I like to have people do it. And then I'll tell you what it is, and then I'll do it with you guys. So you're going to breathe in through your nose. You're going to get all of your air out. You'll blow as much air as you can into the balloon. As you're blowing up the balloon with your right arm, you're going to reach forward like you're just trying to reach real far forward here, and you might feel a little stretch in the back of your shoulder. So and then we'll do about 3 breaths in the balloon, and don't make it pop. Usually 3 breaths we're safe if it has active as well. So everybody breathe in, And then blow out, blow, 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 blow. Get all your air out and reach, 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 reach. Get all your air out and you're going to pause for 5 seconds. Good. 5, 4, 3, 2, 1. Good. Breathe in through your nose. And you're going to blow it up again. Everybody, you're looking awesome. Good job. Nobody does this good at first. Good. Pause 5, 4, 3, 2, 1. We'll do one more. Good. And okay, now this is the fun part when you get to let the air out. Good, good. Everybody did perfect. That's it. That's impressive. Good. And then you can let it out. And that's my favorite part.
Damn, girl.
So yeah, I think my neighbors think that I play with whoopee cushions all day. But yeah. So that was excellent. So that's just a quick and dirty example of one of the more common exercises I use to go after all these asymmetries and muscle imbalances. But it really doesn't have to be super complicated. So this helps because it gives your diaphragm a weight, it gives it a little bit of resistance. It starts to correct the rib flare, it starts to get your abs to fire a little bit. And in my mind, I would always think of these sorts of things as an orthopedic or like a joint or a muscle problem. But, especially because this is a pain talk, I think a lot of times, now I start to think of it as, yes, we were getting muscles to fire, or we're getting stress off of joints, we're getting things maybe a little bit stronger, but at the same time, I think we're also playing with the central nervous system and getting it to chill out a little bit and downregulate through respiration, through breathing. So a lot of the stuff that I like to use will incorporate breathing to some extent, because it's not just, okay, here's a tight muscle, we have to stretch it out, or a tight joint, we have to like pop it and get it to go. It's really playing with the central nervous system, getting the
Which I think is a great point too, starting up. It's
Yeah,
a good
yeah.
point for nurses. This isn't something that, or any other therapist, we don't necessarily need to have some, if you're like, well, he said something about our liver weighing too much, I mean, you can just say, hey, it just helps us relax. You know what I mean? Just let's try blowing into the balloon.
Yeah, totally.
It's
Yeah.
a trick.
Yeah, definitely. Anything to get the body to relax. Let's see. That's good. Yeah, and you can do this again. You don't have to be up against the wall in a 90-90 position with your feet all positioned funky. You can do it in a bed or a recliner. So we gave it a shot. That being said, it's not a silver bullet for everybody. Everybody's going to be a little bit different. It's one of the more common exercises that I'll use to get people repositioned before I go into the retraining. And a lot of times I'll get the question, man, you're blowing up a balloon, really? Do you have other stuff that you do? And yes, we have more traditional stuff. I mean, it's not to say that everything that you're doing now is bad. I just use it I kind of incorporate it into the stuff that you're already doing. You don't have to throw everything that you've learned out by any means, because the stuff you're doing is probably awesome. But we've got traditional stuff. We see people using foam rollers and pec stretches and things like that. It's just one more thing to think about when you're treating your patient. So I feel like I've kind of tried to fit like 10 pounds of stuff into a 5-pound bag. So I just want to go over a couple of key points. So we've got pain education when we're dealing with chronic pain patients. We've got the pain education. We've got the Explain Pain book, the Painful Yarn books. And that can help to kind of have a conversation with your patient. And usually I'll do that while I'm doing other stuff. So you don't have to take out 30 minutes or an hour or something, some big chunk of time. I just might be doing it while I'm doing other things with the patient, just talking with them. The manual therapy doesn't have to be crazy advanced techniques. It can be basic things. A lot of times your patients, especially ones that haven't had anybody touch a painful area before, a lot of times they've been through lots of doctors and nobody does like a physical exam or touches them. Nobody's put their hands on them before to try to make a difference, and in some cases that can have a big impact. The corrective exercises. We've got our silly blowing up a balloon. That's one of my favorites. All different types of things you can do for corrective exercises. Get the person out of pain, downregulate the central nervous system. And I say with these types of things, you can help to decrease pain, even if it's just a little bit. And it can give the person some hope, because a lot of times they can be pretty upset and pretty hopeless in a lot of cases. Even if they're not homebound, the folks that I'll see that come in, they can be pretty bummed out. And the good news is you guys get to keep the balloons too. But yeah, they can get pretty bummed out. So it's nice to be able to give them a little bit of hope and kind of get them over that rough hump and start to make a difference for them. So does anybody have questions on anything?
How long do those exercises take when you want to get the diaphragm real line?
Oh, great question, great question. So I'll do a lot of testing and retesting, and I'd say majority of the patients, we can get them repositioned or neutral, usually after one visit. The tricky part is keeping it that way. So that's where we'll give it to them to continue. Sometimes they may have something else that's going on that prevents them from getting into that good position. As strange as it sounds, it could be the way their teeth fit together. It could be something going on at their foot. It could be that they are in so much pain that they're so guarded that right now it's just not going to work for them. But usually, majority of patients, we can get them neutral after the first visit, I'd say. And then from there, might start to do a couple more things to solidify that good position, and then start retraining from there. Yeah, that's a good question.
When you did the balloon exercises, you had them reach with the right. Is that just the problematic side? Would you do the left?
Oh, good question. Yes. So definitely, you still want to assess your patient, but I would say at least 9 times out of 10, you're going to have them reaching with the right arm. Even if I have somebody that has pain on say their left shoulder, I'd still probably have them reach with the right arm because, and there's definitely exceptions to the rule, but usually they'll hurt on one side for one reason and hurt on the other side for another reason. But if you can correct those rib flares, and usually that left side is going to be flared out, and if you can correct that with the right arm reach, then it doesn't matter where the pain is, or well, I shouldn't say that, but most of the time we'll be doing a right arm reach. Yep, that's a really good question. Yeah.
So you were talking about Greg Cook's comment about treating dysfunction first before exercising.
Yeah.
So a lot of times, in the home environment, you're dealing with these comorbidities like emphysema, like you suggested, where you can't clear that first.
That they may be hurting for some other reason.
So say you see a patient who's got emphysema as something else, but you're also treating them for neck pain. So in that circumstance where you can't necessarily permanently clear it to treat on top of it, how do you approach that?
That's a good question. So yeah, not everybody's textbook for cut and dry, and probably most of the people you guys see lots of comorbidities and lots of stuff going on. So I would say easy answer is you do the best you can, because these people will still benefit. And I would say probably somebody with emphysema, because they've probably been breathing kind of wonky with those secondary respiratory muscles for so long, that they would probably benefit from something like this even more than your standard walk into an outpatient clinic type person. So even though something like that might be where you're thinking, okay, I'm doing everything that I know to do, but they're still coming in a funky position. Some of those people, that might be the reason why they're not getting into that good position, because of the lung pathology that they have. So we'll see that a lot too, but it's still okay to go after and try to get that diaphragm as well positioned and functioning as best we can. And then in those cases, I would just ease into it and progress as best you can. But yeah, that's a good question, because yeah, not everybody will be cut and dry for sure.
Yeah, I was just thinking about Butler's approach. You try to down-regulate things, but then is your corrective exercise almost going to upregulate it back? True. That's a good point. So with the exercises, I would say it'll let them know that they can move in a comfortable range, and in that case, I would say it would down-regulate. Now, say we did that exercise with somebody and they reached and said, "Oh my gosh, you know what? That really kicks up my neck pain." Say, "Okay, cool. We won't do the reach. We'll just do the balloon." Or say, "You know, I'm still feeling it." Say, "Okay, we're just going to do the exhale. And instead of sitting up, let's try it. We're going to lay down on your back with your knees up instead to keep them comfortable, but just to still get them a win and try to go after what I want to go after, assuming I still think it's a good idea." But you can temper and play with things for sure. But yeah, that's a good point. But I think if we can get them to do an exercise comfortably and to move comfortably, then we'll go back into that Butler way of thinking of getting them to downregulate, where they're not so afraid to do anything, sort of thing. Yeah, good question. Good questions.
I have more of a comment about a takeaway here that I think is hugely important for all of us, even if some of this stuff isn't necessarily going to be explicitly what we're working on in our discipline. The idea that we can